Good morning, everyone, and thanks for joining us today. I'd like to call to order the Behavioral Health Subcommittee of the Incarceration Prevention and Reduction Task Force. Today is Tuesday, January 18th, the day after the day that we honored Martin Luther King. For us to go ahead and get started today, I'm going to go ahead and read into our land acknowledgement. Before we begin, we acknowledge that we are gathered on the traditional and unceded territory of the Lummi, Nooksack, Samish, and Semiahmoo people who've cared for and tended this land since time immemorial. We believe that truth and acknowledgement are critical to building mutual respect and connection across all barriers of heritage and difference. And we do this in our meetings because we want to bring what has been buried by honoring the truth and bringing it to light. We pay respect to their elders, past and present, and please take a moment to consider the many legacies of violence, displacement, migration, and settlement that bring us here together today. And please join us in uncovering such truths at any and all public events. Before we begin, I'm going to do an item that's not on our agenda before we get into our rich topic of methamphetamine, because I believe we have some new members. Dan, if I could turn it over to you. And
hey, Courtney, do you want to, you can come on or turn your camera on?
Hey, yeah, let me. Hello.
Hi.
I am the new behavioral health specialist for the Public Defender's Office.
Great. Well, welcome aboard.
Thank you.
Brian?
Yes, hello, everyone. My name is Brian Estes. I'm with an organization, the National Alliance on Mental Illness, the Whatcom County chapter. I'm the vice president. I'm also on the NAMI Washington has a public policy committee. So I've been very interested in a number of the issues that this group has been dealing with, as well as some of the issues related to the City of Bellingham's Police Department and Whatcom County Sheriff's related to crisis response. I know I'm in a meeting every once in a while with Officer Clicks from the Whatcom County Sheriff's Office. But anyway, very much looking forward to working with this group to improve, especially issues related to criminalization and mental illness.
Well, welcome to both of you. Good morning.
And, since they're kind of new, we could maybe just have the members go around and do a really quick 30-second intro, maybe, so that that our new members, Courtney and Brian, also have a sense of who we are. So I'll go ahead and go next, and then I'll just tap somebody and we'll go down the line super fast. So my name is Mike Parker. I'm co-chair with Dan Hamill of the Behavioral Health Subcommittee. My day job's at the Opportunity Council and Housing and Healthcare Integration. My personal passion is housing and removing all barriers to getting people housed, because I think when they're housed, then we don't have to pick them up on the street. So that's one of my key lenses that I bring to this every day. And I'll go ahead and pass it to co-chair Dan Hamill.
Thanks, Mike. Dan Hamill, Bellingham City Council, Ward 3 representative, entering my 8th year of service. My focus is primarily on criminal justice reform and homelessness and housing, and then economic development for our, especially for our downtown area. And I'll go to Brian Thane.
Good morning, I'm Brian Thane. I'm Executive Director of the Housing Authority of Bellingham, as well as the Whatcom County Housing Authority. And I'll push it to Doug.
Good morning. My name is Doug Chadwick. I'm the undersheriff here at the Whatcom County Sheriff's Office, and I've been going on 28 years now. So I started as a patrol deputy and worked my way up through the ranks, and have held a variety of specialty assignments across the way. So I think I have a pretty broad skill set and experiences within law enforcement. So I think that's what I bring to this group. Obviously, we deal with folks that are in behavioral health crisis on a regular basis, and doing what we can to work collaboratively with our behavioral health partners and try and get folks the help that they need.
My name is Arlene Feld. I'm the co-chair of the Legal and Justice System Subcommittee. And I worked for 10 years in the what was called Whatcom Crisis Triage program. Before that, in private practice, currently training new counselors out of several clinics in this community.
Thanks, Arlene. Who do you want to pass it to?
Oh, I don't know.
How about
Just
Michael Smith?
raise your hands.
How about Michael Smith?
Sure,
Sure.
Michael. Thank you.
Hi, everybody. My name is Mike Smith. I'm a clinical supervisor at Lake Whatcom Center's Baker Creek co-occurring inpatient facility for folks with substance abuse and mental health challenges. I guess my focus, I really like the reentry field and just helping folks put their life back together. I guess I'll pass it to Chris Cochran.
Hey, nice to see you all. And I missed the second part, or the focus. Is that like what we're working on right now, or?
It's a little bit about what we bring to this committee, I guess, or what do we want out of the committee / what are we bringing to it?
Yeah. Okay, thank you. So yeah, I'm Chris Cochran. I work with Bellingham Public Schools as a mental health coordinator for our district. And I would say the things that I'm focused on right now is with this group in particular, is the intersection between how we're serving our students, both all the way from pre-K up to 12th grade and beyond, and their families, and the upstream stuff we've talked about around how we can be part of helping prevent some engagement in other systems like the legal system and stuff later on. So the mental health supports we can provide, substance abuse supports, those things that a lot of things to learn from this group. Thank you. Is there anyone that hasn't been called on that I can pass to?
I'll go ahead, Chris.
Mike, thanks.
Hi, good morning. Mike Hilly, I'm the Emergency Medical Services Manager for the county. And I spent just short of 30 years as a paramedic down in Keene County, down there, past military in the Coast Guard, similar work, and took on this job, be 4 years here in March. And really more of my passion, especially related to this group, is, understanding how EMS can better help these patients at, right place at the right time. And I'll say over my 30 years, I've seen this, in particular, the drug issue explode in the hands of EMS. I mean, EMS was just never designed for this typical work, back in the 70s and 80s when this idea was dreamed up to pull people out of wrecked cars and save hearts, etc. So this is a large amount of the EMS workload, and I'm here to figure out better ways to not only respond to those patients, but hopefully maybe change their life or direct them to better services in our little community. Thanks.
Great.
I'll go.
Byron? Okay, Stephen.
Welcome, Courtney and Brian. Glad to have you in this group and in the task force orbit. My name is Stephen Gockley. I'm a retired civil legal aid lawyer and the co-chair of the Incarceration Prevention and Reduction Task Force. I'm also on the Board of Commissioners for Brian and the Housing Authority, and a couple of other community involvements. I think this is one of the two cruxes of the work of the task force, and I'm glad to be a regular part of the conversations.
And Byron, I don't think we've heard from you yet.
Hi, I'm Byron Mannering, Executive Director at Bridget Collins Family Support Center. And, our particular focus, of course, is on child abuse treatment and prevention programs, having trauma treatment services for the kids, and also doing support for the investigations of child abuse cases through our children's advocacy centers. My particular bent on and approach or focus in being on this group has been related to prevention, providing prevention services that will actually eliminate the likelihood of incarceration, and also bringing forth the victim's voice to make sure that things that we're doing to try to address the behaviors and challenges that are associated with those who have committed crimes is one thing, but we can't do that in light of making it worse and harder and more traumatic for the victims. So that's what I've been bringing to the table. I've been on this task force for 8 years now, and heading off. So it's probably my last behavioral health meeting, but I might join every once in a while and see what's going on. So thanks.
Byron, you would be more than welcome. And just so you know, when you sunset on the main one, you can always stay in a subcommittee for as long as you want. So, but we would also understand if you have other calls and pulls on your time and appreciate your service. Perry, I saw you pop on. We're just doing quick intros to welcome Brian and Courtney to our group.
Yeah, sorry, 3 days off and I forget how to use Zoom. So my apologies. I'm Perry Mallory. I'm Services Supervisor with the Health Department. And I work with a lot of the different providers and support the Crisis Stabilization Center. And I'm involved in a number of different components in terms of providers and processes that are going on. And so great to be here.
And then we also, Brian and Courtney, just for your benefit, we have some amazing Whatcom County staff who help us out. So you'll see their names down there. And more than that, they'll pop on from time to time. Jill and Jackie, I wonder if you wouldn't mind just giving us a quick shout out so they kind of know who you are.
Hi, everyone. My name is Jill Nixon. I am a legislative coordinator with the Whatcom County Council Office. And Jackie is with us, but she does not have a microphone today. So Jackie, also with the County Council Office, is my superwoman, assistant, helper, and backup for the task force.
Thank you both. And we would be lost without their help. And they also help us with Robert Rules of Order. And if we ever have to do action, you will see them be very, very instrumental to the work of this committee. So thanks to all. Thanks for allowing us to do that. I know it takes a little bit of time. To be quite honest, I really loved hearing kind of what do we want to get out of this and what do we bring again from some of you that I've been on this committee with for a long time. I found that kind of refreshing. So without further ado, we're going to go to our first item on our agenda. In our agenda pack, which I believe is a 5-page packet, but the agenda is on page 1. And so we're on to number 2, which is methamphetamine use and treatment. Dan, if you wouldn't mind, maybe just tee us up a little bit. I know this is one of the things that you really wanted to see on this agenda. And maybe if you wouldn't mind just giving us a little bit of context and some rails about some of your thinking before we bring up some of your presenters.
Sure, thanks. Yeah, I just have some concerns around the new meth that is on the streets. It's the phenyl to propanone. And then the other concern is, was on a ride along with Captain Joe Frank from Bellingham Fire, and he talked about these new drugs that drug dealers are making. They're benzodiazepine and fentanyl, and they make the pill together, so they're both together. And yeah, I'm seeing some more. I'm seeing some folks downtown that are they're sleeping in unusual places, and I'm wondering if it's an effect of the second drug I just mentioned. They're called Hulkies or school buses because they look like little Incredible Hulks, or the yellow ones look like school buses, and so that's what folks call them. So I'm concerned because there's really no treatment option for the meth, and for the fentanyl. I'm not quite sure if Suboxone or oh gosh, what's the other one? I'm totally blanking right now. If there is a treatment option that's effective for the fentanyl, and I'm not quite sure how it works with the benzos. And so yeah, those are my concerns, and I just wanted to hear from folks that are a little bit more in the know than I am to see if there's any way to get ahead of this stuff. And I was hoping that Doug or Mike Smith could maybe just guide us in this conversation.
Sure, I'll jump in here real quick. Sorry, Doug, don't mean to just step on your toes there. As far as, things are always changing in the community as far as what type of drugs feel better to the clients, and the drug dealers they're gonna put together what they think their customers really want. What we see here and working in the inpatient center is that a lot of folks are coming with, it's kind of hard to talk about meth without talking about opiates or fentanyl, because those are the cuts now, right? They're cutting the drugs with the fentanyl and the carfentanil, which is 50 to 100 times stronger than the fentanyl. A lot of folks on the meth, they just get way too high. They become manic. They're kind of out of their minds. With the opiates, you just get way too low. And so what the drug dealers' clients are wanting, the community is wanting, is kind of like that good vibe, that equal flow, right? I mean, you got the fentanyl that's bringing them down, you have the meth that's bringing them up. So they kind of find a balance where they can function and just kind of float. It's more of a euphoric feeling. Meth, folks, I've seen, I work with Dr. Khan down in Pierce County. UW, I think, has some research out where Vivitrol has actually helped meth users. It definitely helps folks with opiates. It wasn't being used for opiates, but now they're finding that Vivitrol and buprenorphine, which is Suboxone combined, is actually working for it all. It works for fentanyl as well. Fentanyl's hard. It's kind of hard for us to get a panel test to actually test for fentanyl when they get here, because it won't be picked up by a urinalysis sample that tests for opiates a lot of times. So they kind of fly under the radar. Our test for benzodiazepines, which is what you were just talking about, but there's no detox really in the area that will even touch clients with benzodiazepines. I think there's one in Seattle. So literally you can send folks to detox for everything else except for benzodiazepines. Benzodiazepines and opiates pretty much is a cocktail for death. Straight out, there's no cut. I mean, it's kind of over for you if you get the wrong amounts in your system. Alcohol as well, but with meth, I mean, there's not like many deaths with meth. UW also had a study where I think in 2020, the research is always going to be behind, it's going to lag a little bit. Where in 2020, I think Washington State had like 810 or 807 deaths just from meth itself. I know that number is probably skyrocketed now that meth is being cut with fentanyl and carfentanil. So the folks that we see coming here used to kind of be meth a few years ago when we first opened, but now it's no longer just opiates either. There's that combination of both. And benzos, we send them to the hospital. The hospital really doesn't kind of do anything. They kind of have to have a primary care that will titrate them down. We don't have a license for that. I don't think there's anyone licensed in quite a few counties to really work with folks with benzodiazepines. So we can help the people with the methamphetamine and the opiates or the fentanyl, the carfentanil type of substances that are out there. It takes work. Suboxone, buprenorphine, what you were speaking to, really can flip them in about 24 hours. It can get them stable. They just have to have some time detoxing off of the opiates. We've seen 12 hours, 8 to 12 hours, you can actually probably start administering Suboxone in their systems without creating precipitated withdrawals. But I'm interested to see how the community, the county, the state are going to start adopting Vivitrol and Suboxone together to actually combat these addictions, because people, turned their noses against it. They didn't want to see it. They said it wasn't made for that. It's hitting on the same receptors. I mean, it's addiction. So it is actually made for it, it just wasn't funded for it. The people who put it together, that's not what they created it for. They created it for alcohol use disorders. But it actually works really well for meth, according to the evidence we saw when I was working at a methadone clinic and a Suboxone clinic down in Tacoma and Seattle. So we know that it works. It's just getting people on board to actually take that chance and start doing it. And like I said, there's a couple studies out there that talks about it. So that's about what I see. I mean, we get folks to the detox, send them to the hospital, get them back, get them on Suboxone. They get pretty stable within a few days. The meth is not such a bad detox as the opiates, but within a few days, we can kind of get them running normal again. And we do see some changes, but I mean, when they go back out to housing and it's the same people that they use with, they're in the same community, we see them again. It's like a revolving door. So until we can get them completely stabilized with all of Maslow's hierarchy of needs, it's just a repetitive cycle. But I mean, that's about all I can give you guys.
Well, you've given us something that looked a little bit like a glimmer of hope. And I think we were kind of not feeling a whole lot, especially in the regards of treatment with methamphetamines. It sounds like this is kind of an emerging science. We'd certainly like to hear more. Doug, if it's okay with you, since we've got a couple of questions regarding kind of the treatment end and what Michael brought up, we might hit some of those questions, and then I'd love to hear from law enforcement. And I'm a little lost who came first. So I'm going to go Arlene and then Chris.
One of the things I saw at crisis triage many times was damage to the brain functioning. And so my question is it possible for people who have been using meth a lot to get back to any kind of normalcy after they've become sober?
That's a question for me.
Yes, Michael. Yeah.
So I've seen, we work in the field with folks who have recovered. And so I would have to say yes, from working throughout the counties up and down the corridor of the I-5 from the bottom to the top of the state here, that there are folks in our field who do quite well. They go to school, they get degrees, their brains are functioning. What I see personally, when I, interact with some folks who have used meth to, I guess I would say a strong extent, is memory. Sometimes the memory is not as sharp as it should be. And I'm not trying to put folks down in any way at all, but it's a pattern. It's my honest opinion of a pattern that I see. So, I would say yes, for sure. They can come back and be productive members of society, and buy homes and have car notes and everything that we do. But there is some deprivation of cognitive functions after a lot of use. Yes.
Yeah. Thank you.
Hey, Michael. Hey, Michael, I had a question for you as well. You were talking about that there's a couple of things. You talked about the treatment centers around here not really touching the benzos and things like that, or people that are using that stuff. You also talked about titrating down. So I was wondering what that looks like in terms of when a lot of times, as people have said, the drug stuff that we're seeing now, nobody would have predicted that 15 years ago necessarily. So the things that might have been developed as, hey, this is a treatment for this, we're going outside the box and having to demonstrate that this works, right? And then people say, okay, that works. And that happens all the time with medication. So I guess my question for you is, what does that titrating down look like? And do you think, in addition to that specific question, when you're looking at treating people with this type of usage, is it going to be something we've seen in the past where you just kind of find a program that demonstrates, hey, this is working, and then other programs are willing to jump on board? Like Suboxone clinics that weren't around 15 years ago, stuff like that. So I guess that's my question. If there's no treatment centers around here, what does that titrating down look like? And what do you see as possible steps for us to have that treatment? It's just somebody willing to step forward and demonstrate what we're seeing elsewhere? Thanks.
Yeah, so primary care providers can walk a person down from the amount of milligrams that they're using. This is what I mean, like a titration. They can give them something for, in Tacoma, we call it a kick kit, where folks are kicking off the drugs, right? You give them something for being nauseous. You give them something for the anxiety. You kind of give them medications for all the symptoms that they're going to experience while they're coming down from these substances. While at the same time, the doctor is titrating down the amount of milligrams of the benzodiazepines that the individuals are actually on, or whatever level that they started at. But then they're coming off. Or either they get to a low dose of 2 milligram Valium or something like that. But we find folks are shooting it, smoking it. I mean, they're doing everything possible. As far as treating it, I guess doctors would just have to be willing to do that. I don't see why. I'm not a medical provider, so I can't go too far into the realm of why they wouldn't. It is dangerous if they're using opiates. I don't know if folks think, because they're shooting heroin in their own benzos and I'm touching the case now, could I be liable for that? I don't know what actually all plays into that. But I just know nobody's doing it. Nobody wants to really deal with it. We try to get them in detox. It won't happen. The hospital, we've had some success with the hospital actually doing it. I guess it depends on the doctor that's on and how comfortable the doctor is with working with that type of population. So I really don't know what the barrier is to addressing it. But it's to the point where, somebody walk in the door and they weren't honest in the assessment. And the next thing you know, they're detoxing off of benzos. Well, they can't die here. Like, we can't even accept them, with that. They have to go to a detox first. Well, then what do? There's nowhere to send them. So do we deny them treatment because they have nowhere to go, but they're trying to get off of drugs? We want to help them get off, but there's nowhere to send folks. So it's a sad cycle. But yeah, good luck getting somebody into Seattle as well. I mean, their lines are, out the door. So I think folks just don't really understand it. That's not their scope. Maybe we need some trainings in the state. Maybe, from the back end, get folks trained on what that looks like. And doctors who actually do it step up and participate in the training. But I think there's definitely room to open detoxes for everything, for benzodiazepines especially.
Thanks. It sounds like people are doing the work to other places, but it's just getting the knowledge base shared here, so people feel like it's less risky, even if it is a high risk thing. Thanks.
Brian Estes?
I just had a question about the Crisis Stabilization Center. Is that the substance abuse component of that? Is that something that could be doing this? Is it titration or what he was just describing? Is that something that they could do there?
Perry, I know you don't run the place, but I was wondering if I might pick on you. I see your hand. Okay, go ahead.
Sure, absolutely. It's a great question. As Michael had shared, benzodiazepines have a long half-life. And that means that it stays in the body for an extensive period of time, and it definitely has synergistic effect or a multiplying effect in terms of opiates and other sedative type substances, and so very risky. And so to my knowledge, they are not capable of actually doing detox specific with benzodiazepine. They'd be very cautious about that. And again, as Michael had said, they would engage the hospital. I can't recall now, but a couple of things in terms of some of the discussion earlier was that I thought that Providence Hospital in Everett actually has an addictionologist on staff, and they will, do some of that on, I think it's a case-by-case basis. And, again, I would absolutely underline what Michael said, that it is a risk in terms of the detox of an individual, because there is a great possibility of serious illness or death for an individual that's detoxing from benzodiazepines. So I can confirm that, and I'm speaking a little bit beyond my knowledge, but to my knowledge, that is something that is above the level of care that the detox facility can do, even though they are a medically monitored facility, and certainly can do some medical detox processes, which is a step up from where we were in terms of our triage facility in the past. The other thing, at least as I understand it, in terms of looking at, the issue of using Vivitrol and some of the things that we were talking about, is that if it's not approved for that by the FDA, then it puts that physician at risk in terms of, utilizing it. And so that's where the concern, begins to come up if it's not well established. And so you're absolutely correct. You have those individuals that are pretty knowledgeable about it and will work with some of those components, and that gets more and more and more established, and then it finally gets approved is essentially what goes on. A couple of things that I'd like to, if I can, also throw in here, at least from my perspective. I have a background in terms of substance use disorder treatment and clinical supervision and some of those kinds of components. And I think that, it's interesting in doing the research that one of the things that's been somewhat successful in terms of methamphetamine treatment has been contingency management. And it's a fancy dancy way of basically building in a reward system for individuals. And that has so far anyway been the most effective treatment modality for methamphetamine. And so, which is kind of interesting because most treatment programs honestly have contingency management built into it. It's a behavioral kind of an approach with individuals. And actually, I'm a pretty big fan of it. The other thing that I would say, and I think it's fantastic that we have, obviously inpatient treatment services, here locally and the resources with Michael and some others. And I continue to encourage that, at least from my background and experience, and it's more of I guess, a professional, personal observation that inpatient treatment is absolutely necessary. The effect of methamphetamine and usually, as Michael made reference to, multiple substances, is not something that will, that an individual is able to respond to treatment services without a fairly extensive, time period of involvement and that level of care. And so, although, of course, we're dealing with Omicron and, and all those components, but I continue to encourage folks that it's like, if there isn't availability for services here because they're full, and that's a good thing, the success of keeping facilities full, is to refer that individual throughout the state to inpatient settings of where an individual has the opportunity to, go through that initial process of detoxification and then, into the actual involvement in treatment. And that is, as we made reference to before, it's very much a holistic response. I thought that Arlene's question was really interesting when she was making reference to, this impact is horrendous, especially with methamphetamine, and, can an individual really sort of come out of that? And I find that it's very much a holistic approach. If the individual is not eating well, is not getting sleep, is not getting services and support, and that combination factor, it doesn't tend to be effective. The individual tends to, go to a 30-day inpatient treatment, come out back into their community, have all of their friends and family, et cetera, and be exposed to methamphetamine use. And in those given situations, the recidivism to return to active use is pretty common. So those are some factors that I think that we're going to have to take a continued and real serious look at. I've had, great concerns just in terms of, I think it's fantastic that we're able to address opioid addiction through MAT services, has saved a lot of lives and so forth. One of the things that I think that has created is that there, of course, as we talked about, isn't something like that, some medication specifically for methamphetamine. And so when you have an individual that is using opioids and also using methamphetamine and you treat the opioids well, what you have left is methamphetamine addiction that continues on, and then very commonly the individual returns to opioids. So, it's kind of that revolving door that I think that we have to continue to pay attention to. It'd be great if there were something that was a medication that we could, utilize to have an effect on it at the level that we have with opioids. But I'm not optimistic, to be perfectly honest with you. I think that there's substances that can help, but I'm not convinced that holistic treatment of addiction is not nearly as effective as a medication would be. That is the right food, the Maslow's hierarchy of needs: food, the shelter, the support, and the healthcare. So anyway, I offer that up and continue to encourage the individuals at the Crisis Stabilization Center to use inpatient agencies for methamphetamine to refer individuals to, whether it's within the county or somewhere else in the state, as an effective tool of addressing that piece. So just my 2 cents worth.
It sounds to me like one of the things that would be useful in meth treatment, or probably all treatment, would be the use of navigators to assist and stabilize and keep a person on track with all the different elements that Perry is talking about, and thank you for your contribution, Perry, because the knowledge that you have is so useful here. Thank you.
All right, we'll go to Stephen, and then after that, it will shift to law enforcement and what we're seeing in terms of trends and various things. We can always come back to treatment. Stephen?
Thanks, Mike. Perry, thank you for your comments, and I'd just like to follow up a bit. I was glad to hear you mention contingency management, because there was just something in the mainstream news about some research that was quite promising in that area, including actually paying people for staying clean, horror of horrors. So I guess I'm wondering whether there is anything in that area that's potentially beneficial enough that could be explored locally, or if that is still going on in the research world nationally, and 10 years from now it'll filter down to the ground level locally, or whether we could sponsor pilot projects or any way to pursue that promising avenue.
That's a really interesting question, Stephen. We actually use contingency management in the mental health court. Individuals that are involved in mental health court are surrounded by a support system, identified, specific risks to their ongoing recovery, whether that be substance or mental health in nature. And oftentimes the individuals that are involved in mental health court are co-occurring disorder. And so it's why I'm making reference to it here. It's extremely effective. We have gift cards that are for locations that will not exchange the gift cards for mood altering substances like alcohol or tobacco. And so it's very interesting to watch this process. The gift cards are a $10 value. The individual can earn a certain amount of points and then make a choice in terms of which kind of gift card they'll get, whether it's a Goodwill or Dollar Tree, those kinds of gift cards. And so it is, again, as I had mentioned, a really, really common practice. And actually the research, and, I'm a little out of my wheelhouse here, but the research has actually been out on it for, I'd say, more than 10 years and continues to be researched at this point. An interesting side note of this, I've been involved in a variety of different treatment facilities and programs, and contingency management has always been a component of it. And it doesn't have to be really large things necessarily either. And it can be very creative that the individual gets a certain amount of points and gets to draw from a bag. And they can actually get gifts of, whether it be, commonly in the group that I was working with was you could choose socks or, toiletry type, things or what have you that the individual. But again, the contingency management, it doesn't seem to be necessarily connected to the amount. The value of the gift itself. It's the reward system, and I suspect anyway, it's connected to the reward system and the brain release of endorphins and enkephalons when you win something, and how you feel when that occurs. And so I suspect that it's probably tapping into the same brain system that the substances are mimicking. When we introduce those. So I think that it is something that we can grow further. And I really agree also with Arlene's earlier statement about navigators. I think that folks are aware that we have a recovery navigator program that's coming into the county, which is specifically made up of individuals that are substance use disorder professionals, and that are connected to a variety of resources in following and tracking individuals to make sure that they stay connected, or if they do get disconnected, reconnecting them to the resources and substances of. We basically know that it takes 5 components to grow a human being: physical, mental, emotional, social, and spiritual. And we can identify where the risks to that individual is, and then enhance that by walking with them over to, the needs that they have and making sure that they stay connected to it. So I do think that that's a really important component that we are further developing. And then that, of course, I should have mentioned the Recovery Navigator program. The goal is to connect them to the LEAD program, as well as with GRACE. And so hopefully that process and knowledge gets spread throughout those established groups. I'm making reference to LEAD and GRACE, with a greater level of knowledge, specifically related to individuals that are struggling with substance-related disorders. So I think it's a really good track that we should continue to develop. And I think that that's something that it's one of the interesting pieces about this is sometimes we get some feedback from the public that they can't believe that we're actually giving people money for staying clean and sober, because we tend to come from a belief system that you chose to get into that problem and you need to pull yourself up by your bootstraps and get out of that problem. And I'll tell you, one of the things that I concluded in the years that I've been involved in SUD services is that if pain and suffering caused people to stop, everybody would be clean and sober. Because it just doesn't work that way. The greater the pain and suffering, the more likely it is that the individual is going to return to their active use. I'm sorry to say. So great idea, and it's certainly something that I'm supporting in the variety of activities and work that I'm doing in the community through the health department.
Now, I know we want to move on, and I just want to kind of springboard off of that. Mr. Perry and Miss Arlene's statements. The National Institute of Drug Abuse Clinical Trials Network and the National Institute of Health, NIH.gov, speak elaborately about the behavioral health component, like the navigators, the contingency management piece of treatment, and the combination treatment of Vivitrol and buprenorphine all together as a holistic piece of treatment. And it's pretty extensive. They've done a lot of clinical trials where the medication piece is what is, I guess, the latest research on top of the contingency management and the behavioral piece that has now been added. So the medication side of it is coming forth. They're showing the evidence that these components work together. And if you guys want to check that out, it's at nih.gov. You can just kind of Google combination treatment for methamphetamine, and it'll kind of talk about everything that all has kind of been touched on here today.
Well, thanks for that coverage. I'm getting a lot today. I'm learning a lot. I actually Googled that while we're talking, was able to find that study. It's pretty easy to find. I'm going to put a pin in the Recovery Navigator just because that kind of lit a little spark, and this group might want to come back to that. Perry, thank you for introducing that, sharing that news that we have a program coming in, and maybe hearing more about it. We'll understand as a committee how best to fine tune it, or where to give feedback, or where to do requests, or how do we hear about its rollout and how successful it is. I'd like to shift, if we could, to law enforcement, because with every new combination of drug, what we've seen in the past, for those who've been on this committee for a while, is it ripples into law enforcement. They end up seeing it often, sometimes before our treatment providers do, and it can also cause different responses, or demand different responses from officers, or liaising with other emergency professionals. So Doug, with that, love to hear, I know you've talked to this group about meth before. Obviously we have a little different flavor that we're talking about today, but anything that you can add to this about what you all are currently seeing, and any feedback that you have about connecting the individuals that your officers are seeing into these treatment modalities.
Sure. It's a little, you talked about trends we're seeing. I just looked at our numbers basically year to year. So we're early enough in 2022. So essentially it's a comparison of 2020 to 2021. And our incidents of either arrests or contacts involving meth, opioids are significantly down. And that I think that's to be expected with some of the legislation. But what we are seeing, and I know Michael talked about it, and Perry as well, of those people we are coming in contact with, many of them are polydrug users. We used to, when we would contact somebody, they were either a meth user, a heroin user, a cocaine user. But now we're seeing people that are using both a depressant and a stimulant, cocaine and heroin, or another opioid, methamphetamine and heroin. But when it comes to the opioids, I think anybody that works in the medical field, and quite frankly, you probably have family or friends that are dealing with within their own circle. The opioid crisis continues. We have seen the amount of overdoses, specifically related to fentanyl overdoses, continues to rise. So that is something that at the jail we obviously have the MAP program. I think we're going on 4 years. with that program, and it continues to grow. So Suboxone, and I don't want to, I believe if they don't have it, they were working on Vivitrol, which, you know, and as Arlene talked about, that navigator, that warm handoff when somebody goes out the door, if they can get a Vivitrol injection, that's supposed to last, you know, 30 days. And hopefully, you know, when they leave, they are put in contact, but at least they have something that can assist them for that 30-day period. So that's something that we've been working on here. Chief Jones has been on top of that for quite some time. But again, the costs with that continue to go up as well. And we want to continue to maintain that service and that ability for folks that are incarcerated. As far as new drugs, I agree. Our task force members go to an annual conference, and that involves people from not just all over Washington, but Idaho, Oregon, Alaska, and everybody's seeing the same thing. Obviously, fentanyl is kind of front and center, that a lot of counterfeit oxycodone, hydrocodone that are laced with that fentanyl is responsible for a lot of these overdose deaths. And the other thing they're seeing is, and I think Michael alluded to it, is other drugs, meth, cocaine, even marijuana is being laced with fentanyl. So it's a lot of poly drug users. And then our patrol folks, and then our behavioral deputy, we have 2 behavioral health deputies, and they regularly interact with folks that are not just, you know, they have co-occurring disorders. They have a mental health issue, but also a substance use disorder, which may or may not be their way to help manage that mental health issue. So a lot of things going on, but again, as far as what we're seeing, we're just making a lot less of those contacts just because of you know, some of that legislation. But I don't believe that the problem has gone away, or that it's you know, within the last year there's been a significant reduction in the amount of drugs or the amount of persons that are addicted.
Thanks, Under Sheriff Chadwick, for that coverage. That's incredible. I did have a question, then I want to go to 2 others who are popping in with questions too. One of the things that really struck Councilmember Hamel when he was talking to me about this agenda, why we wanted to put this on, the way that people acted on this P2P, which I guess is the acronym, right? That people are using for the new type of parafentanyl, was pretty intense, and I think it sounds an awful lot like somebody in a psychotic episode. And I'm just curious, you know, with the passage of new legislation where, you know, somebody's in a behavioral health crisis, but they're not in a danger to self or others, and they're not about to perpetrate a crime, is there, in your opinion, is there any chance that we might be missing some of those, really, because we have to police a little differently in response to some legislation?
Well, again, I think we've seen a reduction in proactive policing, which is, you know, you would just, as a regular, you know, part of your routine patrols, you would contact more people, but also some of those people that we would normally take for an ITA, take into protective custody. There's kind of that gray area. So I think some of those people that we would normally take to the hospital to be seen, you know, they're being left in place. Obviously, we're trying to enhance our ability to get behavioral health specialists out in the field with our deputies. I know Perry's working on at least 2 positions, and we're also meeting with the Grace and Lead program to have a caseworker assigned to the sheriff's office to hopefully get resources to where people are, as opposed to bringing them to Bellingham or St. Joe's or the crisis stabilization facility. If they don't meet that threshold, at least getting somebody in a timely manner to meet with them and try and get them the help that they need immediately, rather than a referral and something that may take 3 or 4 days.
Great. We'll go Councilmember Hamel and then Mike Hilly.
Yeah, so the ITA piece is concerning to me. If we're unable to get a person to help that they need because of legislation, then that's a concern. I know that Representative Goodman who is one of the key people on House Bill 1310, is working to try to come up with a fix to it, but it's not being supported very well by colleagues on either side of the aisle, so to speak, or by the ACLU. And so I don't know that there's going to be a legislative fix to that. And if there's a reluctance from law enforcement to either show up at a call or respond differently when they're at the call, then I'm just, it's unclear to me how that person would be assisted through the current modalities. So we are working on an alternate response team. Sheriff's Office is working on that, and BPD is working on kind of different model, where the BPD one would be pardon me, it's actually, well, Perry's actually working on it, and Dean White, who graces this committee once in a while, and others, Mike Hilly, I think, has been associated with it. And so it kind of started with fire. Now it's kind of going over to the Whatcom County Health Department to some extent, and hopefully that'll be up and running by the end of March. And I see that as one of the only things that that type of response is one of the only things that can address certain types of behavioral health calls. Ones that are dangerous, they're not going to get sent to those. So if there's, we had a incident where a person was banging on a window downtown at a coffee shop, and the owner of the coffee shop had her baby with her, and the man outside was pounding on the window saying, "That's my baby, give me my baby." They called dispatch, and there was no response. To me, that's borderline. It could have been dangerous. I don't know. I wasn't there, but that was reported to me. So I'm all that to say is that alternate response is a way to get through this. I'm worried about the ledge in terms of there being a legislative fix. And so this just keeps kind of coming back up again. And so I just wanted to put those comments out there.
Sure.
Thanks.
And just to comment on that, I sat through a update last week, and I understand there's two different bills. One's to address more the civil commitment when it comes to ITA's protective custody for juveniles, those situations. And then there's a separate bill that's talking about use of force, physical force in a criminal situation. So maybe the fact that they're split may get a little more traction. I think everybody recognizes that needs to be a fix because it has caused some issues. And I can't give you actual numbers, but I think anecdotally that's probably impacted some people not being taken into protective custody and provided with the assistance they need in a timely manner. But
Mike Hilly?
Whoops, sorry.
Yeah, just two small points, and reflective of Dan Hamill's comments, which was, in fact, Perry and myself just got out of the alternate response planning meeting right before this, and there is opportunity there to divert, and that's something that I continue to represent over there, because I do feel like, I know more than half of the people, if not 75% of the people that are waking up out in the field, specifically for opioid overdoses, leave against medical advice. And so we lose that opportunity for some engagement. And out of that alternate response team, I hope to create a diversion narrative to the new crisis stabilization center that would change that idea that, at least you'll get some engagement and maybe an outreach there. And if this is the day, it's the day, welcome, we'll admit you. And so I think that's a real important part of that team. And as Arlene and we work in the other groups too, the other piece is better developing a crisis stabilization center to have more to open door and take people in on an irregular basis. And so I think we can get there, but it's just capacity building. I do want to say, I just emailed this to Jill Nixon. There's a regional group that is led by a King County Medical Examiner's Office, and it's the Washington State Fatal Drug Overdose Surveillance Network, and they put out a bulletin every month. I just sent it to Jill, and she's welcome to send it out to the group. But in particular, this report gives a monthly snapshot of what's killing people in the region. And so just from a high level view, it's showing 28% meth, 31% fentanyl, broken down by 11% of poly drug overdoses, 11% just straight up heroin, 7% alcohol. And I think this is important to know because our county has not been participating in this surveillance network. However, we have a new medical examiner that's joined the county here this year. I've already reached out to Dr. Hunt to see if we can have the medical examiner's office participate in this reporting, because it's very indicative of trends and what's going on out there. So I hope to get included in that. I'll reach out to the ME to get in that program. But as Jill emails the report, I think you'll find some interesting information on exactly what Perry was talking about and Michael Smith of the relationship of the type of drugs are out there and these polydrugs overdose, because it's just not a simple heroin overdose anymore. We're waking up.
And my apologies, Doug. I think I may have cut you off when I was asking Mike to come speak. Did I cut you off, Under Sheriff Chadwick, on something?
I just wanted to point out, I know there was Councilmember Hamel was talking about law enforcement not responding, and I can't speak for other law enforcement agencies, but we still respond. But again, depending on the circumstances, once we get there, if there's no criminal activity or there's no imminent threat to themselves or others, then one of the options is obviously under the duty of reasonable care is to leave the scene. So, and I know that's what causes some concern for our fire and EMS folks, as well as the mental health providers that are out in the field. So again, that's why we've kind of been working on this co-responder model to be out there in the field with those behavioral health specialists. And I think, especially for some of our more remote areas of Whatcom County, that's a great option.
Great. I'm going to call on Courtney and then Brian, and then just a quick heads up. I'm going to do just a call, and I'd like to hear a little bit about housing and maybe what's happening to housing folks. As I mentioned, one of our key things of people that are housed get arrested a lot less. And a lot of the people we're talking about today are actually unhoused because they can't maintain housing. But I know meth has been a scourge for housing providers. So Courtney and then Brian, and then if it's okay, Mr. Thane, I'd like to call on you after that to give us a little housing lens. So Courtney, you first, and then Brian.
Hi, yeah, I just to Dan's comment about the gentleman and the baby situation. I don't know what took place there, but I'm wondering what communication was had between DCRs and law enforcement in circumstances like that. Because in our conversation about the House bill, I'm hearing a lot of talk about law enforcement, but I'm wondering where the DCR piece is coming in.
Brian? Oh,
I was just going to say, I don't know. That's a great question, Courtney.
Okay, yeah, because I guess I'm just a little confused and surprised because they are the designated crisis responders. I'm just wondering what's happening. I recently moved over from Spokane, so what we have over there is the logistics are a little different, but it just sounds like there's a lot of community concern about responses to on site to things like this, and I'm just confused where that partnership is happening over here.
I think operations could probably provide some clarity. Mike Hiller might be able to respond to that.
Yeah, I would just generally say, and I know law enforcement deals with them as well, so Doug may have a similar insight, but the MCOT teams and the DCRs are really not considered first responders. Not only that, they're spread pretty thin across a 5-county region. And so there's a bit of a process for activating a DCR to come to any scene out there. Usually a significant time wait as well, because those teams are small. So it's not that they're not interested, it's just that they're overwhelmed, and the current system really just doesn't support those teams being first responders in those situations.
Understandable. And yeah, completely. I know there's a complete lack of resources in every way. Yeah, it's just, I was hearing law enforcement a lot. And so I was just wondering about that, how we're communicating that to the community. If, even if in an ideal situation, there would be more resources and more time, but are we communicating that it is a partnership so that community members know who's who and who can do what, including DCRs?
Brian?
Yeah, I just wanted to share that HB 1735 is legislation that specifically addresses limitations in last year's 1310. And it does specifically address the Involuntary Treatment Act and is generally supported by law enforcement. As I listened to the first hearing of the Public Safety Committee on the House side. So I'm hopeful that will be a significant improvement in clarifying some of this. And of course, the Attorney General has yet to issue this guidance on defining use of force. So whether or not that makes any of these bills or not, I'm not sure, but I think this is an important issue to track during this legislative session. And I don't know if Doug has any comment on that or not. But.
No, I think, like you said, that was my understanding as well, is they have called it out separately. But as you noted, I don't believe the Attorney General's office has until June or July of this year to issue that model policy. So obviously we'll be looking for that, but I would envision that it will be incorporated somehow into the new legislation. But I think everybody from law enforcement to the legislature and the mental health and behavioral health community all support changes of the law when it comes to physical force and ITA situations. It's like I said, it's caused quite an issue for everyone, and quite frankly, it's caused some safety issues, and people aren't getting the help that they need.
Perry, I see your hand up. Before I go to Brian, was it kind of regarding what we were just talking about? Did you have some? Please add.
It is, Mike, and actually to add to Brian, House Bill 1735 and also House Bill 1589 that Doug had made reference to, I sent those on to Jill, and I think that she sent them on out to us if you care to take a look at them. So they're in draft, but they both actually address the issue with stipulated pickup orders and ITAs and those kinds of things that we have some real concerns on. So I just wanted to offer that.
Great, thanks for that. So I'd like to call on Brian Thane. As you all know, he runs the Housing Authority and oversees probably one of the largest portfolios of housing in Whatcom County. And Brian, we've talked about it in this group, how housing people with meth can be a real challenge as well. And while we know that that's one of the best recovery supports is housing, and as Perry talked about the massive hierarchy of needs, we know how crucial it is. But we also know it's not without some challenges. And I'm wondering if you could just maybe speak to a little bit, maybe current state, or what you think, if you have a solution or a thought that might be really effective for reentry housing for those, especially addicted to methamphetamines, which we know can damage housing.
I wish I had a suggestion of solutions, Mike. It is very challenging for us as a housing provider, and I'm referring specifically to smoking meth. Smoking meth, as far as I know, unlike any other drug, it turns the apartment or the rental unit into a hazardous waste site. That poses a risk for folks entering the site. We've even had instances where there's been cross-contamination between units, not because of any shared ventilation, but rather the build up within the unit eventually can permeate walls and start bleeding out into neighboring units. So it's a real challenge the longer that it goes on. When I joined the Housing Authority not quite a decade ago, meth smoking seemed to kind of ebb and flow. And we'd have a smattering of contaminated units at this property, and then that'd quiet down and it'd move over after a few months to another property. Now it seems to be more constant. It's early on, remediating the units could cost us easily $30,000 to $50,000 a unit. Cleaning technologies have advanced. Our understanding of how to remediate units has advanced. And because we do have a large portfolio, our maintenance teams have learned how to do much of the remediation themselves. And so we're able to keep it more down, generally in the $15,000 per unit, per apartment, to remediate. When we do it ourselves, it can be twice that for a 2-bedroom unit. When we bid it out to third parties, it's costing us hundreds of thousands of dollars a year. In a bad year, it can be pushing up north of $750,000. So it's real challenge, because we do recognize that being stably housed is fundamental to people's efforts to recover. On the other hand, we can't afford the having the property turned into a hazardous site that is dangerous to visitors, maintenance personnel, and potentially neighboring units.
Thank you for that coverage. At Opportunity Council, I just put on my work hat. We have permanent supportive housing. And for those of you who are not familiar with that, that means that you do not have to be clean and sober to enter clean and sober housing. And the idea is that stability, wraparound services, and supports will help people enter into recovery. And evidence shows that's true. It takes time, and not everybody makes it into recovery, and damage happens. And it's both an incredible cost and an incredible opportunity. I know it can be extraordinarily expensive. Brian, does the mitigation fund, does that help the housing authority all? That the Department of Commerce has created? It's a mitigation fund for damages that exceed security deposits. For those that aren't familiar, I guess my first question is, can housing authorities take advantage of that? And do you know, does it address that issue?
So I just recently learned, Mike, that State Department of Commerce that runs the landlord mitigation program says that housing authorities are not eligible for that program. They've admitted that the statute language is unclear, but they've decided that the program simply does not have enough money to accept applications from housing authorities. So that's a bit of a head scratcher. My understanding is the landlord mitigation program has helped private landlords, including some of our landlords who accept housing choice vouchers or Section 8, remediate after meth contamination. So that is helpful in encouraging those landlords to sometimes take a bit more risk, or at least what they perceive as a risk, real or not, in accepting voucher holders and other low-income folks.
Yeah, thanks for that. That's important to know, those little tidbits about what things aren't being covered, because I think our next topic is reentry, and at some point I will move on to our next topic here. I want to hit Michael Smith's comment first, but it's so crucial, and why I wanted to touch on housing, and Brian, I really appreciate you bringing that up. It's such a critical piece. If we can't house folks, it's very, very unlikely that they're going to be one of those 9 people that responded to treatment that we're seeing in research, right? I mean, it's an absolute critical piece. If landlords are afraid that if they serve somebody who maybe is lower income or maybe is substance use affected, it'll destroy their property, they're going to be very cagey. So it's really kind of a holistic piece, and I really appreciate the 3 lenses and you all speaking to each of those pieces. I'd like to go to Michael Smith and then Stephen Gockley.
This is more of a thought that I had while hearing the conversation from Mr. Bryan. I wonder, has there been any research on when housing meth users by smoking, how brick or some sort of different texture of housing has affected the cost or lowered the cost for housing individuals like that? I mean, I know it probably seems like an institution But like coming out of treatment, I just had this thought of like how this flow would work. They would come out of treatment, maybe go to like a brick type of facility where if they did use, for like a year, and maybe if they did use, it wouldn't cost so much to the county or the state. That 15 could go down to 5 if you only have to worry about the ceilings or something like that. So just a thought I had, and want to know if you had any information on anything like that.
We have learned to rebuild a bit differently. Cabinetry materials, especially, some are more porous and absorbing. So we are learning to use some different materials.
Stephen.
I know from working with Brian and the Housing Authority that part of the challenge of that job is that you are both a housing operator and manager and a service provider to the tenants who utilize that housing. So I'd just like to ask Brian, I think you did a good job talking about issues in this area from the housing management perspective. Can you talk about barriers to access to housing that substance use disorder tenants or applicants might have? There used to be HUD rules that prohibited people with criminal records or people still using drugs from even qualifying for housing assistance. And so, as Mike said, you do better when you're housed, but if you have barriers to being housed, you're less likely to do well. So I'm just, if you could speak from the tenant side of the interaction between the housing programs and the kinds of issues we're dealing with here, I'd appreciate that.
Sure. For public housing, which is, well, we have a bit over 500 public housing units and 11 or 1,200 non-public affordable housing units. For public housing, HUD still bans folks who have been convicted of manufacturing meth. Of course, manufacturing is less and less common, at least in our experience over the years. We try to be as flexible and discerning as possible with folks' background checks, and nothing is just if you check that box, forget it, you're out of here. We try to scratch beneath the surface and understand the circumstances. And with our affordable units that are under third-party property management, we've also been monitoring that more closely and pressing them harder on the point. We do fortunately have very strong partnerships, both with Lydia Place and the Opportunity Council, providing case management and services to a lot of our rentals. And that's really key to folks' success, of course. There have been times in the past when it's a bit of a challenging relationship, but between our landlord hat and our case managers, who their ultimate goal is to keep their client stably housed, and we're looking to balance that with our concern for the property and the safety of the neighbors. Did that get at what you were asking, Stephen?
Yeah, it did. Thanks, Brent.
So this has been a really good discussion. We've got a couple of we've got a little bit of time left, and I did want to touch on reentry, but before we do that, there's just one piece that's just sticking in my craw, and it's what Under Sheriff Chadwick brought up, and he talked about how there's counterfeit pills being made, right, which are of varying quality and the way they're constructed. You may have some people cutting in half, and I remember what I thought it was in Bellingham, but a student actually taking half a pill and figuring that they were going to take half the dose. Well, if the pill is made by somebody who's not following quality control, you may get 100% of the dose and half the pill, or you may get like half of the substance in the pill. But Under Sheriff Chadwick also brought up to this group about marijuana, which of course is commercially available and is going to be tested by the state, and you'll know it's clean. So I'm guessing that the marijuana, and I don't want to be guessing, so I guess I'll ask you pointedly, Doc, is that more of a risk to folks that can't buy legally? And I guess I'm thinking of youth. Because if we've got laced marijuana going around and most adults can buy it, from a regular store, is that a particular issue do you see, Doug, in youth? And maybe Chris Cochran after Doug, if there's a comment.
Yeah, and I'd have to check with our folks that went to that conference. I don't know of in specific incidents here in Whatcom County, but that was something that they brought up at that multi-state conference as something that they'd seen. So I can get more information on that and maybe report back next time. But I would agree that it'd probably be something that would be more black market available, somebody that's growing outside the state process, not a licensed facility, a licensed grower, and go from there. But I can look into that and get you some more information.
Chris, I'm just wondering if you had a comment about that, or if you're seeing any of those issues amongst students, especially high school students.
Yeah, and I apologize. I was kind of managing something else at the same time. Can you just clarify your question again?
Yeah, no problem. The question was really about, there's a couple of issues that we heard regarding different drugs. One was laced marijuana. And given that it's legal in this state, I was wondering if that was more of an issue for youth. And then the other was when we were hearing from a couple of our folks today that it's quite often pressed into pills by people by drug dealers doing it on their own, which means that to a user who wants to chop a pill in half, and I remember a story, and I don't remember if it's this community, it was a high school student who took half a pill, thought he was getting half a dose. Got a full dose and caused problems. And I'm just wondering if you are seeing this issue in youth and young adults.
Yeah, I mean, I don't know if it's specific to that, but like Michael said, I think people are making what they think is going to sell, right? I mean, so that changes so fast that in school settings, especially in high school settings, we see the trends change so quickly in what's some of them stick around if they're really effective and effective in a terms of economic setting. And so, and the laws for school discipline have drastically changed. I believe it was July of 2019, kind of like this last year, law enforcement, they had huge impacts to their job. Our job was hugely impacted in schools in terms of what we can do in good ways and bad ways in terms of how we can address drugs on campus. And so both in terms of usage, possession, and distribution. And so I think we have seen, a lot of the concern has been around fentanyl stuff, because we did lose a student about a year ago, just over a year ago, in one of the high schools. Although, as you probably know, we have to be sensitive in terms of what the family wants shared in terms of the cause of death and stuff like that. But in terms of what you just described, we see, thinking about our 4 high schools, I ended up talking with admin and the counselors quite a bit about possession, but also and usage if kids are coming high, but also distribution in schools. And so I think the main thing is we focus less on the specific type of substance and more on the dynamics of the distribution in terms of what that's looking like, because obviously it's wrapped into the social fabric and how we can try to prevent that or at least disrupt it. And because of some of the laws around school discipline, which are often really positive, and all of them are in positive intent, it can create a really difficult situation for us to respond in ways that can prevent those things. So I don't know if that answers your question, but I would say we focus less on specific substances and more on how can we create a safe environment in the school. And of course, parents we tend to hear more about things like fentanyl and heroin, things that kind of get headlines, but it can also be, like probably 10 years ago is when edibles were really hitting the fan. And we were having a lot of kids that were thinking they were taking whatever was equivalent to a joint, but it was equivalent to 10 joints or something like that. So we'd have kids passed out or, so I think those things just evolve so quickly. We're more focused on, we have people like the prevention intervention specialists that are really focused on more substance treatment. And then the wellness side of things, the prevention side of like, what are some strategies that kids can learn so they're not just turning to use for stress management? So I don't know if that answers your question, but that's kind of what we focus on.
No, that's great. Perry, and then we'll move on to at least teeing up reentry services today. Go ahead, Perry.
Yeah, a couple of things in this regard. I actually, during our meeting, had emailed the manager for the detox facility, and he indicated that they do, in fact, do detox for benzodiazepines as long as the amount is 2 milligrams or less per day for the last 30 days. So they do some work depending on the amount and what the level of detox would be. So I wanted to pass that information along. Something else that actually caught me by surprise, and maybe everybody else is informed, and I was the last in the door. But one of the things that I've really found interesting when Chris was talking about the fabric and that it's part of the context, not specifically making reference to students, but that fentanyl is actually something that users are pursuing. And obviously with the emergency notifications that go out, and it's like, hey, we've got, fentanyl laced substances, watch out, be careful out there. I was always looking at, individuals, wanting to avoid that. And in fact, that's not necessarily accurate. I mean, the information that's out there is that users are actually pursuing fentanyl, very dangerous, obviously, because of the potency and et cetera of it. So anyway, I offered that information up. And Mike, maybe to a segue, I also had sent something to Jill that might be helpful for folks relative to the reentry component. And that was that I was just looking through. We had back in 2020 a service inventory and strategic plan. If you'll recall, we did the SIMS model relative to services within the community and really sort of broke that down into great detail. Just the variety of services that were going on, relative to the intercept that would occur. And I just sent that to her and said, it hasn't been updated in just a little while, but there are definitely some pages that talk about community services, law enforcement, and a lot of folks did quite a bit of work on that and could probably update from the document that was in 2020. Obviously, we have some new things that are going on. So anyway, I just offer that up.
Thanks for that, Perry. So with that, and thank you for that segue, Perry, you see our second agenda item, we haven't left a lot of time for that, but we have talked a little bit about reentry along the way. So my hope today, I didn't want to interrupt that conversation. It was a pretty good one. We've got a couple of takeaways. I'm going to mention just in the interest of time, just before we run out of it, HB 1735 and HB 1589. Stephen, I don't know if the steering committee has thought about that or really how we interact with legislation during the legislative season. But we've got a lot of savvy folks, a lot of people that care, a lot of people that could provide testimony or push things the right way or not. And also, given what we saw last year, it occupied a lot of the task force's time. So we had some troublesome legislation that was really identified as being kind of a fix, but we had some challenges in its implementation. So I just wanted to highlight those couple of pieces. And Stephen, I don't know if that's something that steering might take up and talk about is what is the task force's role in educating or urging or people to be active in the legislative process.
Well, great question, Mike. My recollection is, and I'm going to guess it was 2 years ago, the task force explicitly decided that we had to pay attention to legislative action and insert our voice when appropriate. And I think the past year with some of the legislative reforms underscored that. So I definitely think those are the items that the steering committee can track, take a look at, make recommendations about, and I'll try to put a bug in Barry's ear. And Jill, if you could put that on your list of potential agenda items for steering committee, that would be great as well.
The other one that I would just add that I wrote a note on, which is while Brian Thane was talking, sometimes it's not a piece of legislation, but there might be a fix. And obviously we've got housing authorities precluded from accessing mitigation funds, which might help them house folks that have meth use disorders and are going to be reentering. So, you know, that's kind of a different advocacy type of issue, but I think still salient nonetheless, especially to our topic today, right? Which is, you know, how do we go into reentry? Brian Estes?
Yeah, Stephen, I just wanted to mention, I'd be happy to share with you NAMI Washington's legislative priorities related to mental health and behavioral health treatment. I think some of the bills line up nicely with some of the goals of this subcommittee. One of them also is just increasing Medicaid reimbursement rates for behavioral health specialists to 7%. I mean, I think it's 3% in Inslee's budget, but that's really key to helping have more behavioral health participants be reimbursed at a reasonable rate. So I'd be happy to send that to you directly if you're interested.
Yeah, the reimbursement rate is a huge issue that's come up repeatedly in this group, so that would be relevant, definitely. And thank you for that offer, Brian. If I could suggest that you send that to Jill and Jill circulate it to the committee membership, that would be great, and we'll try to pick up on that. Thanks, Brian.
Will do.
Thank you for that. So with the last few minutes, obviously, we're not going to be able to tackle reentry. My hope was to kind of tee up that our next meeting's discussion, which we will not table reentry, we're really going to get into it more in depth. I'd like to hear from task force members, what would you like to have as rails in that discussion or particular issues to make sure we speak to? Or third, is there a particular person you might like to hear from when it comes to reentry? I know for one, I'm really interested in Perry's recovery navigators. But with that, let's just popcorn style. And if you would, you can just come off mic. And again, our purpose here is to really tee up kind of the subject areas within reentry that might be most germane for us at our next meeting. So with that, I'll stop with my reentry navigator, and anybody got anything they'd like to see in that reentry conversation? Again, you can just come off mic. I'm not going to call on folks. We only got a few minutes, so popcorn style. Brian, Estes, or Arlene?
I know I've heard from some of the treatment centers about some of the challenges that they are facing. I don't know which one come to mind. I can consult with the NAMI executive director who knows a little bit more about this on that. But just that whole process and related to specific going to a treatment center and it just doesn't work out for a variety of reasons. And so what are the reentry protocols that are not working there?
Great, helpful. Dan and Arlene.
Arlene, go ahead, get your hand up first.
Oh, okay. Well, I would really, Jill sent me several pieces of research, which I've been reading about the services. So a lot of research has already been done. It isn't necessary for us to invent the wheel, but it is important, I think, for everyone to read this research so that you can understand what the basic essentials are. I think we're going to need to figure out where the money is going to come from for reentry services. I think that's really vital. Somebody to speak about that would, that would be important. But there's a lot of knowledge, so it's just a matter of accessing it. So try to read that material. Jill, if you could send it to everyone, that would be great.
Arlene, are you talking about the materials that Raylene sent around from Harvard University?
Well, she sent me some, and I thought you did. I could have been.
Okay, thanks.
Okay, Dan.
Yeah, so what I'm trying to get at here with this reentry discussion is basically asset mapping to figure out what are the assets in the community, where are the gaps in services, And I think it would be helpful to line this up with our sequential intercept model and then the GARE toolkit. So I'm hoping, and we have new members, and it might be just beneficial, Jill, if you could just send out the sequential intercept model just to everybody, so we have it. We have a, and then also the GARE toolkit, so you can at least have some kind of like guardrails, as you were saying, Mike.
Okay, that's really helpful. People can reach out to either your co-chairs, Dan and I, in the meantime, about items that you might like to see in our next committee meeting, where we're going to dive into reentry services. And if you have any suggestions for anybody that's got something particularly useful for this group to digest or hear from, we'd be interested. And you can do that outside of this meeting as well. We have about actually 0 minutes left. And with that, I'd like to see, Jill, do we have anybody for public comment?
We have 2 people attending today's meeting. If either of you would like to speak to the committee, please virtually raise your hand now. No hands are raised.
All right. Well, I want to get us out of here on time today. Thank you all for the robust conversation. Again, a hearty welcome, and I'm loving hearing the testimony and the input from Brian and Courtney. So thank you both for joining our austere group, and we look forward to seeing you next time. Thank you all.
Thank you both, or everybody.
Our meeting's adjourned.